Good evening, everyone. I don't know if you can hear me. Good evening to our guest, Dr. Itumo. We're really excited to have you here. Thank you so much for honoring this invitation. So the event will be starting very soon. We're just trying to give chance to some of our listeners to also join us here. So today is the third edition of our monthly events. We always have different topics to talk about. Last month we did let's talk about assisted reproduction, and it was really beneficial to several people that joined us. We had a doctor from Evercare Hospital in Lagos that was able to put us through several things that we didn't already know about assisted reproduction, and he was able to answer some questions also. So today we have with us Dr. Itumo Ogechukwu. He's a doctor in UCH. He's in the psychiatry unit, and he works in the psychiatry unit, and today we'll be talking to us about depression. I know several people have questions about that, and we already have people on our website that have some questions to ask. Some people are joining on our website, and while some people will be joining us here on Zoom. So please, any question you have to ask, if you are listening via the website, on YouTube, or here on Zoom, any questions you have to ask, please just feel free to type it either here on Zoom or in the comment section on our website too, so that we'll just get into it immediately. The event is just for 1 hour. We don't really have a lot of time, so I would advise that you quickly type your questions as soon as possible so that we can get into it. I know our guest is already on standby to be answering our questions. So thank you very much. Thank you so much, Dr. Itumo, for honoring our invitation. We are really, really, really honored that you answered our invitation. And then, the event was supposed to hold like some weeks back, but due to certain factors that we wanted to walk through, that was why we couldn't, hold it that time. And we really apologize for having to postpone it to now. So I'll just get straight into it. Today, Dr. Ezine Ejele and Deborah will be co-hosting with me. So we will just be trying to read people's questions and then have Dr. Itumo answer them. But before that, I would like him to just talk to us generally about depression. There are some few things that we'd like to know before we now get into the question and answer part. So, Doctor, over to you, sir. Dr. Itumo, can you hear me, please?
Okay, I can hear you now. Good evening, everyone. Sorry, I think I was having a little network issue. But,
Okay.
I hope it doesn't continue.
Yes,
I don't know if you want to see my face. If not, I
yes.
guess it's sufficient.
Yeah, no, we will appreciate the video too, sir. Thank you.
All right. Okay. I just hope it's bright enough. So I didn't really hear the last part of your introduction, but I don't know if I could go ahead to say one or few things.
Yes, please. Yes, I said that you should please just put us through some things. Just talk to us about some things about depression before we start asking the questions.
Oh, okay, that's very fine. All right. Thank you, Anchor, and then everyone who is present on this program at the moment. Well, I hope that the fact that we want to discuss about depression, I really don't want us to discuss it with a depressed face. Yeah, basically, it's expected that when people talk about things that relates to sadness, then they should feel sad. Well, I guess in trying to learn, we could feel happy amongst ourselves, learning the few things we can learn from each other, and then hopefully we use it to avoid the aspects of sadness. So what is depression? One is that depression, clearly the first thing I want to mention, I will keep mentioning till this program ends, is that it is It's an illness. It's a medical illness.
Mm.
It is a medical illness. And it is not just a descriptive time for maybe someone who is feeling sad in a particular situation or who is facing a challenging situation. Now, that is not what we describe as depression. I mean, in the medical palace. So when we use depression, it is an illness, a medical illness, the same way we have hypertension, we have diabetes, we have infertility, as you mentioned, we have malaria. It's an illness. So it's a medical illness. Now, but it is one of the medical illnesses that has refused to discriminate. You know, in the medical world, a lot of medical illnesses discriminate. Is either it is found more in the Western country, or it's found more in Africa, or it's found more in poor people, and rich people. But depression is one of those common medical illnesses that doesn't discriminate, which means it cuts across all race, cuts across all genders, cuts across all ages. I'm sure most people will be surprised when I say that depression cuts across all ages. Children, adolescents, adults, the elderly. Now, it is actually a mental illness, as all of us know. The group of illnesses we describe as mental illnesses are any illness that has to affect the mental process. The mental process is that when you see something, when your eye sees something, there is a process that interprets it in your brain and tells you that, oh, this is black or this is white. Now, if an illness affects those mental processes that helps you to interpret things, that helps you to understand and analyze things that happen in your environment, now such illnesses are classified as mental illness. And depression is one of them. In fact, depression is one of the commonest mental health disorders that we have. And the impact is very high, to as much as about 5% of adults, which is in millions or billions across races, actually get to have depression. And if we look at places where we have data like in USA, in the United States of America, we try to say that all through lifetime, at least 1 in 5 of people. So if you have 5 people, 1 out of that 5 gets to have depression at some time in their life. So, and that is a very high prevalence compared to other medical illnesses that we can think of. Now, why are we worried about depression? We are worried because it is a leading cause of disability. According to the World Health Organization, it's a leading cause of disability in the young aged people. Disability in the fact that in disability, we talk about functioning, which for us in the mental health aspect, functioning is not just occupational. We are talking of somebody being able to function personally. Personally being that you're able to care for yourself, take care of your self-hygiene. Then you have what you call interpersonal functioning, which means this person is able to create a relationship and is able to sustain relationship between the person next to him. And then before we get to the occupational functioning and other functioning. So depression affects functioning across this range that I've mentioned. So it is a leading cause of disability according to the World Health Organization. And it was because of that the World Health Organization in the past almost 5 years has been prioritizing mental health. You may have heard of the recent tag that the World Health Organization has, that they say there is no health without mental health. Now, and that is because every aspect of health is related to your brain. So someday it will affect the way your brain functions. So that is why we are worried about depression. Most people will ask, but when we're talking about depression and being a mental illness, mental illnesses are so many. Now, but they are in classes. So there's a class of mental illness that we call mood disorders. Mood disorders, which means these are mental illnesses that prominently affect individuals' mood. That mood can be described by different individuals in different ways. For another person, it can be being very sad. For another person, it can be being very irritable. For another person, it can be being very tired for no obvious physical reason. So this individual is extremely fatigued at all times, while the other person is feeling persistently sad for a significant period of time. And another person is just irritable for no obvious reason. You just discover that this individual, who is naturally not of this personality, every slight thing in the environment gets him irritable. So undue irritability. So it will be surprising for us to hear this. So it is not in all aspects of depression that we get to see individuals explain to us that they are really feeling sad, or we see them crying or having weepy spells. So there are a lot of other symptoms that characterize what we call the mood disorders. But for depression, the prominent problem we have with depression is that these individuals have what we call low mood. And that low mood can be expressed in many ways. It can be affecting the mood, affecting the individual's energy, affecting, most importantly, the individual's interests in things that those individuals usually like to do prior to the onset of illness. Now, because I mentioned that depression doesn't just have to be that temporary feeling of sadness that you have when you fail your exam. That is not depression. It is not the sadness I feel when I get home and there's no food in the house. It is not the sadness I feel when I go to the bank and queue and I'm not able to withdraw cash at the end of the day. Now, what it means that there are classical things that we need to usually look out for before we say, okay, this is depression. And those are the things we also want people to look out for, because let me don't fail to mention that as much as we know that the government and the health system is doing a lot, including the World Health Organization, to emphasize depression, the manpower is not there, because if you look at the resources we have, health resources we have to attend to people who may have this problem, considering the number of people who have depression, it is not enough, which means it's this kind of program we're having is a very important one to let a lot of individuals know the things to look out for in your friend, in your family members, such that at the earliest point, you're able to recognize and say, okay, this might be something more than what we are thinking it is. And then we can be able to look for solution. As bad and as dangerous as depression is, the good news is that it is treatable in all forms, whether it is mild, moderate, or severe depression. There is treatment for depression. That's the good news. So the question is, how are we able to identify these individuals and get them to be treated? So I think this should be a good background for us. When I listen to questions, we'll be able to give you more details. Thank you.
Yes, sir. Thank you so much. Thank you very much, Doctor. You have been able to cover at least like the most part of what I think we'll even be getting from the questions today. So I'd like to just introduce my co-hosts. Deborah Odimayo is also one of us at Health Facts. So she'll be working together with me today to go through some of the questions that we have on the website. So before we even get into the questions on the website, I would like to ask some questions, just, from my own end here. So I'd like to ask that, how can you tell the difference, just personally, can you tell the difference between if you are just like really sad or like you are depressed? Let's say you have been having this series of down moments and everything, but how can you differentiate what will prompt you to say, maybe I should see a doctor or a psychiatrist, that maybe I'm actually depressed? Thank you.
So to briefly answer that question, there's something we call 5Ds that I would like to mention, maybe in case maybe you've any of us have not heard of that before. Now those or 4Ds of mental illness. Now those 4Ds are also applicable in the case of depression. So the Ds is that one is that there is a deviation from the normal. Deviation from the normal. Now, usually when we are interacting with patients, we look for what we call pre-morbid personality. Is this person somebody that is known to be very cheerful most times, or somebody that is already does know that the personality that is very moody? Now, what I mean by the first D being deviation is that you're noticing that for a persistent period of time, at least say 4 days, 1 week, 2 weeks. So for at least 2 weeks, let us just use our diagnostic limit. For at least 2 weeks, we are seeing that there is a marked deviation in this individual's mood. So that is the first. There should be a deviation. Now that deviation should lead to the second D, which is distress. That deviation is causing some form of distress. Now, the distress can be to the individual himself, it could be to those around him, or it could be to the society at large. So I'm going to make this applicable to some aspects of depression when I'm done with the D, so that we don't miss it out. Then we have deviation, we have distress, and the deviation will also be causing dysfunction. That is the third D. There's a dysfunction. So now let me see if I can run through a little bit of this. Okay, I am sad. I'm getting to feel sad both morning, afternoon, night, most times of the day. And this is the way I've been feeling in the past 2 weeks. And most times I even get excessively worried why I am feeling that way, in such a manner that I think, even though I know I'm passing through a lot, but I am not even able to go to work again or to even go for lectures as a student. So because of this way you're feeling, you're no longer able to function. That is a dysfunction. And it's already creating some level of distress either to you or to your friends. And the fourth D is now duration, which I've already mentioned. If this whole thing now persists for a significant period of time, then you should be worried. I think it is a time for the person to ask for help.
Okay. Thank you very much, sir. Thank you so much. I mean, when you mentioned the 4 Ds, you said there's deviation from normal, there's distress, there's dysfunction, and the duration of time can help to tell a difference. So thank you so much. I'll let Deborah take it from here. Deborah, please, can you just read some of the questions on the website to our host, so we can just run through it quickly?
All right. Thank you very much, Dr. Itumo. We really appreciate it. I mean, there's been a lot has been writing since we started, and I really appreciate what you. So we have some questions on the website, and I'll read them one after the other. So someone asks that, can depression coexist with other mental illnesses?
Okay. In responding to that question, the answer is yes. And I will try to, for instance, mention some of the commonest other mental illnesses that can coexist with depression. One, some of those coexisting mental illnesses can actually be a predisposing factor for depression, or they can have what we call a bidirectional relationship with depression. Now, number one is in mental, in psychiatry, there is a group of mental illnesses that we call personality disorders. Personality disorders. Now, personality disorders usually are assessed when individuals are at least above the age of 18. And one of the prominent ones that is common in our environment is what we call borderline personality disorder. It is actually a personality disorder, but it's also grouped under a mental illness. Now, people that have borderline personality disorder, they have these chronic feelings of emptiness, they have unstable relationship, they have unstable mood, they have this tendency of what we call deliberate self-harm, just to mention but a few. Now, individuals with borderline personality disorder are at high risk of having comorbid depression, which means you can have that disorder and have depression. Another mental illness that is very common, co-occurring with depression is what we call substance use disorders. Now, substance use disorders have what's called a bidirectional relationship with depression, which means that an individual who is depressed can start. Am I audible?
Yes, please, if you are not speaking, please, can you mute your mic? Thank you very much. Please continue, sir. Thank you. Sorry about that.
All right. Okay, so an individual who is depressed can go on to start using psychoactive substances as a coping style, So I am feeling sad, I get to start drinking alcohol, for instance, just as an example. And I take a bottle, and alcohol is a CNS depressant. So it takes away all the thoughts of sadness I have. So I feel good with it. And the subsequent day, I do the same. Now, psychoactive substances have this risk of what we call dependence. So subsequently, this individual will become dependent on these substances and has now developed a separate mental illness, which is a substance use disorder. So we are going to be dealing with substance use disorder and then also be dealing with Hello, I think there was an interference from somewhere.
Yes.
Yeah, Deborah, can I proceed?
Please proceed, sir. But before you proceed, if you are not speaking, please can you mute your mic? You can go on, sir. Sorry for the interruption.
Okay, so in addition to these two mental illnesses I've mentioned, the other illness, the other common mental illness that
I think the host should mute. Daniela, please mute everyone. So if anyone is ready to talk, then we can use our electronic hands.
Okay, I'll do that. Please go ahead.
Okay, so the other aspect I also need to mention is now the opposite aspect of the mood disorder I mentioned earlier, because depression is a mood disorder where you have the low side of the mood.
Hey, help, please help. I'm getting arrested, bro. Help.
We apologize for the interference. We apologize for the interference, sir. I guess everyone is muted now.
All right. Okay. So the opposite, the extreme end of the mood disorder I mentioned is now the high side, which is what we call mania or hypomania. So these individuals are excessively happy for no obvious reasons. They have excessive energy. They don't have need to sleep. They have an elated self-esteem of themselves. So there can be a situation where there is a fluctuating period of depression and the period of mania or hypomania, in which case we can talk about what we call bipolar affective disorder. So these and many other, including psychotic disorders, can actually coexist with depression. So that is why it is usually good to have a good clinical assessment to define what the individual has at each point in time.
Wow, that's really profound. I mean, very versatile and deep. So you said that we can have personality disorder, particularly borderline personality disorder, substance use disorder, psychotic disorders coexisting with depression. I believe whoever the person that asked that would have gotten an answer to their question by now. And the next question we have is that someone is asking, okay, I remember that when you were talking initially, you said that depression is treatable. I mean, I felt like, wow, that's luckily for considering the high rate of depression, thankfully it is treatable. So someone is asking if or what the major reasons for relapse in a person being treated for depression can be. So what are the reasons for relapse in a person being treated for depression?
Okay, sorry. Before he asks that, I would also like to add to what Deborah said. You know, sometimes like someone that is already been treated for depression, let's say that they also start experiencing some challenging situations, and like you have distinctly like distinguished between depression and just mere sadness. But can like other factors in life, let's just say that they lost like a spouse, they lost a sibling, other things that normally just make people sad that might not be the thing causing that depression. Is it possible that something like that can actually affect like pushing someone back into relapse or depression? Thank you. Thank you, Deborah.
All right. Okay. So I will try to see how I can frame a response to those two different questions actually. Now, so the commonest challenge we have most times is in trying to explain to individuals who are not professionals what is actually the cause of depression. And I think maybe I should use the opportunity of this question to respond to that in the most simplest way I can. Now, the cause of depression, for those that speak English, they will say it is multifactorial. Multifactorial in the sense that there is usually no single factor that we are going to pick our hands and say, this is the cause of this illness. Now, but we have what you call, we can group it into what we call biopsychosocial factors. Biopsychosocial, which means there are biological factors, there are psychological factors, and there are social factors that contribute to an individual having depression. Now, in all these three I mentioned, the commonest that people lay attention to, appear to associate with, is the social vulnerability or the social stressors. Now, but if the social stressors were to really be the most commonest problem we have, you discover that depression will not be found in the rich. But the rich people are usually very depressed. Depression will not be very prevalent in places like the Western country, like in America, where a lot of people are even very comfortable. But it is higher there. In fact, the rates of suicide is even higher there compared to even in our sub-Saharan Africa here. So now the etiology of depression, the simplest one we can explain is what we call the diathesis stress model. Now, I use a gun to explain it most times, and I'm going to try to use that. Now, if you have a gun, which is the person we are, a human being that we are, for instance, if you have a gun, the steps for that gun shooting, for instance, or firing, for instance, means that the first thing you have to do is that you have to load that gun with a bullet. So the gun is loaded with a bullet. So you have a bullet inside the gun. The next thing is that they try to charge, you have to charge the gun. And then the third thing is that you pull the trigger. If you pull the trigger, when there is no bullet inside the gun, it is not likely going to shoot. I don't know if that makes any sense.
Absolutely, sir.
Yes, sir.
Good. So now, Using these 3 steps, these just 3 descriptive steps. Now, genetic predispositions, there are biological things that we call genetic predispositions that usually put individuals at risk of having depression. Now, those are the bullets. Even before these individuals are born, the way you were born, by the time you were born, you have a genetic imprint that says that your skin will be brown or your skin will be green. Now, there are genetic imprints that already predispose individuals to having depression. That is the bullet. It is there. And if they give you a gun, for instance, now to identify whether there's a bullet or not, you cannot identify from a distance if there's a bullet in gun A or gun B until you pull a trigger. The one that shoots, the one that you know that has a bullet. So that's the way, as I'm seeing your face, I cannot say by seeing your face that I see the genetic predisposition of you having depression. So now, there are now what we call early childhood adverse events, which is a place that we're having the biggest problem currently. Now, early childhood event is one of the major events we've seen both in research and in our practice as a psychiatrist. At least I've practiced for 4 or 5 years. One of the commonest, the most commonest associative factors to depression is early childhood events. And that ranges from issues relating to maternal depression, marital conflicts, maladaptive parenting, sexual abuse in childhood, or physical abuse in childhood. Now, the truth is that by the time someone is in the age of a childhood, the person's ego has not been built to really defend himself. So most of these adverse events that occur in childhood fractures these individuals' egos, and they continue to live with it. So it further does what? Suppresses what we call their coping, their resilience, their coping strength, the strength they have to cope. So it means that things are easier to break them down by the time they get to adulthood. So in adulthood, that is where now the social stressors now come in. That individual gets into a relationship. That individual that did not have a good parental attachment, he gets into a relationship, for instance, he's going to crave for attachment in a maladaptive manner, such that if anything happens to that relationship, his or her ability to cope with disengaging from that relationship is going to be more difficult for an individual who had a better childhood or who did not have the genetic predisposition. So at this point, this current social risk factor, which is, for instance, a relationship, a break in relationship, or a loss of a loved one, is now what pulls the trigger. So it is not in itself the actual cause of the depression, because if those other problems, the risk factors were not there, even if you pull that trigger, the person will still not be depressed. And in most cases, when you treat these individuals, even though they've lost their loved ones, they can still come out from depression. So that is the little I could say about the theology of depression. Now, why is it that individuals who are even being treated for depression can come back again and again and again? Now, to answer that question, one, you need to identify that there are different patterns of depression. There is what we call unipolar depression, or a single episode depressive illness, like it's occurring for the first time. There's also a separate entity we call recurrent depressive disorder. Recurrent, just as the English is, it means that people that have this type of disorder, there are chances that they will repeatedly have a depressive episode in the future. Now, we also have the bipolar depression. And these are the people who can switch to a little higher side of normal of the mood. And at other times, they can switch back to the low part of the mood. the modality of treatment in each of these patterns of depression is different. And if you miss anyone, if you treat recurrent depressive disorder as a single episode depression, this individual is most likely going to come back. If you treat bipolar depression as a recurrent depressive disorder, the individual is likely to come back. Now, apart from this, on a general note, most mental illnesses belong to a group of medical illness that we call chronic relapsing illnesses. Chronic relapsing illnesses. Now, what we mean by chronic is a commonest example I'm sure everyone is conversant with is something like hypertension. So somebody can be on antihypertensives and his or her blood pressure is normal, and he's now asking, why am I still taking the antihypertensive medications? My blood pressure, I checked it for the last 1 week and it's normal. And the doctor is emphasizing, please, Baba, ensure you use your antihypertensive. Now, it is because these illnesses affect the body system for a long period of time, even when there are no symptoms. So the commonest thing that happens is that when individuals are treated, they rarely adhere to the treatment protocols. So the chances of relapse gets to be very high.
Hello, sir.
Yes, I think Damilola is talking, but I can't hear her.
Okay, sorry.
Oh.
Sorry, I didn't know I was muted. Yes, I was saying thank you very much for your response. And then, Deborah, I think before we go into the question parts, do you have like some important facts or some things you just think we need to know about depression for our audience before we start we continue with the questions?
Yeah, I mean, absolutely. I was reading a particular article and then I found out
Okay.
that we have a very large, I mean, like Dr. Itimo mentioned earlier, there's a large, like a large pool of people who suffer from depression out there. And I mean, you see people and you can't even tell that, oh, this person is suffering depression. But from that number, we can tell that maybe some persons in our family, friends, or maybe colleagues in school or at work would definitely be suffering from depression. So I saw that over 7 million Nigerians suffer from depression. And then you see the we see the trend, a very high trend. I think about 50%, over 50%, I think 26 to 50% of clinical patients who suffer chronic injuries or chronic illnesses like stroke. And then meeting some of them in the hospital, they are not interested in life anymore. They just say, oh, I can't walk anymore. Or maybe people that have severe spinal cord injury, they undergo depression a lot. And I also saw that depression is quite higher in females compared to male. So, I mean, there's a question about that in one of our websites. So I'll just love us to ask Dr. Itsumo about why the reasons could be. I mean, why that gender disparity among female and male? Why should depression be high among them? And then another fun fact I saw was that there's something called postpartum depression. So that's I think 1 in 10 women undergo depression after giving birth. I mean, those are some very splendid stuff that I saw online.
Thank you. So I'd like Dr. Itimo to pick that question that you mentioned. That's why is there this disparity between females and males with depression?
Yes. So as Deborah clearly mentioned, depression is clearly more prevalent in females in females than in males. And we've continually had this question, why? Well, one of the commonest reasons that has been proposed from research and from evaluations is issues relating to sex hormones. So a woman has almost a cyclical change of the reproductive hormones, the estrogen, progesterone, and these are steroid hormones. Now, the fluctuation in these hormones actually, because I didn't want to go into the complexity of the pathophysiology of depression because it's a medical thing, actually influence the onset of depression, as in influence the reason why we have depression more prevalent in females than in men. In fact, the ratio is almost as high as 2:1, which means that is very high. It's commoner in females. Now, that also explains to you why depression is also very, very common in pregnant females. So the depression in pregnant females is not just postpartum depression. As a matter of fact, we have a very high prevalent prenatal depression, or what we call perinatal depression. That's the best name we use to describe it. So perinatal depression, both depression during pregnancy and after pregnancy, the prevalence is very high, and it is actually it's disheartening because it has both impact on the mother and the child. That is even the most available evidence we have in research that is very worrisome. So maternal depression affects the child in a very significant way, both biologically and emotionally. Now, the other second reason, apart from the sex hormones, is just the fact that females appear to also take a lot of double roles in the society. So it has been social roles, yes. When we talk about social roles, so we, I don't know, most people might not agree with us, but you see in most cases that females have what you call chronic, like roles with chronic stress. So you possibly have most women be the ones that do the more of taking care of children, which is a chronic stress. And in addition to that, she is still working. So she still has to juggle with the stress of work and then with the background chronic stress of maybe maintaining the family or caring for the children or taking other roles. So that is also another reason that has been considered to be responsible for that. There's a recent theory of what we call the ruminating response style to women, to females, which is noted to also be a predisposing factor for that prevalence. What we mean by that is that there's a coping style that has been noted in females that they get to think more about, I don't know, think more about failures, its causes and consequences, more than they act to avoid it. Which means most times they spend a lot of time thinking about failures, a particular set of failures, and what the causes and the consequences that can come out from it, rather than acting more, like taking a decisive decisions. So, but the most one that cannot be disputed is the effect of the sex hormones. So that could actually explain why we have depression very common in women.
Oh wow. Wow, thank you very much, sir. So I mean that's what I've known about why depression could be more common among females than male. So we have generally the sex hormones and then the chronic stress they undergo and the ruminating coping style that you said. Thank you very much, sir. So the other time you were talking about the biopsychosocial cause of depression. You said that when you were discussing why people with depression often have relapses, and it occurred to me that the way you said it, that means that okay, a person with depression, that depression can be avoided and then it can be managed or it can be affected either before it can be caused or affected by biopsychosocial cause. So I was thinking, what are the things that we can do for people we know are depressed? Okay, apart from the fact that they have to undergo medical treatment, what can I do? Maybe I have a friend or a colleague who is depressed. What can I do to the person? Because we also have to factor in the fact that they are usually not interested in talking to people. They want to be on their own. So what can I do without being intrusive?
All right. Well, if you have to do something, you definitely have to intrude. You're already intruding once you're doing something. So people are always running away from, I don't want to, let it not be like I'm intruding, let it not. But if you say it's your friend, definitely you just have to intrude. Because once you are getting involved in somebody's life, you are intruding, but maybe you're doing that for a purpose. Now, first thing I have to say first is, the first thing you need to do as a friend is one of the things I guess you guys are already doing with this program, trying to be able to identify depression. To identify depression is difficult too. There are people, I'm sorry, I have to use the language that is not so proper, but there are people who are depressed and they are more cheerful than the most cheerful person you can see in your office. It is not about looking gloomy. In fact, people who are more severely depressed, who are most likely going to commit suicide, for instance, will most likely not be very gloomy. And we rarely even communicate. So now, there is something one of our psychiatrist, Beck, called Beck's triad. Now, this is what you need to look out for most times. So Beck's triad talks about a triad, three things, where people have negative thoughts about self, negative thoughts about the world, and negative thoughts about the future. Three things. Negative thoughts about self, about the world, about the future. Now, the truth is that life appears to always have two sides, which means life appears to be dichotomous. So there's a positive side, there's a negative side. So if you get, for instance, to be in contact with this your friend, that in the past 1 month, in every discussion you're having, there is never any time he sees a positive side of things. And it's always the negative side is about all the failures she has been. She has always been a failure in all her life. She has not achieved this. She has not achieved this one. She's not achieved this one. And in the world, the whole world around him, there's nothing good at all that individual is ever going to notice. And the same thing about the future. With this present thing he sees, there's nothing bright at all. There's no hope. And that leads you to maybe the feelings of hopelessness that most people can develop at some point. So, primary thing you need to do, look out for this. Not every individual who is depressed will come to you looking sad. The other thing you need to look out is that when people keep complaining about physical, there is a relationship between depression and a lot of physical health symptoms. You see a lot of people who will complain of chest pain and they've treated ulcer for 10 years. Most people are just having somatic symptoms of depression. And when we get them, they may have wasted their money on ulcer medications, and you treat their depression and those pains are gone. You get your friend who is very, very tired for no obvious reasons most of the time. So, in summary, just make an effort to pick one of those few features of depression we've mentioned, identify it, and then discuss with this person that, well, it is, in as much as this is something everybody forbids, we understand the stigma about mental illness. Nobody wants to accept that I have a mental illness, because in our environment, it is like a crime. Just like it was a crime for people to give birth to twins some years ago. I hope all of us know. There were times that if you give birth to twins, they will throw away the twins and then you will be in trouble. In fact, the family will be crying. But these days, if you give birth to a twin, the family will be celebrating and they will even go to church with a cow for Thanksgiving. So hopefully one day we get to that aspect where mental illness is not stigmatized. People don't suffer stigma. So once you identify the symptoms, you have to encourage these individuals to possibly seek evaluation. What are other things you can do to them? The other things you can do for them is that the need for social support is very important in treatment. So even when they go for evaluation and they are to get maybe a medical treatment, like giving them medications or having what we call talk therapy, that is psychotherapy, they also need what we call social support. Social support are people who are around these people and make them still feel that they have a value within themselves, because they don't see themselves as being valuable. They see themselves as being worthless. They see themselves as being hopeless. They see themselves as being helpless. So having people around them who still make them feel they have some value can actually help, even while these individuals have a proper evaluation and they have medications if need be, or they have psychotherapy where need be. So I think if we're able to do this, we may have been able to help our friends. And most importantly, please don't tell yourself that you don't want to intrude. You have to intrude. I want to say this, sorry, please. I think I've taken long on this question, but I have to say this. Mental illnesses most times act like the car battery. You know, if your car battery runs down, you have to do what? You have to jumpstart it, which means you need another battery. So that battery is intruding. So once your friend, for any reason you suspect is going through a challenging time or maybe facing a particular mental illness, please, you have to jumpstart that person, which means you have to intrude. Because the person, that car battery that has gone down will most likely not start that car. So don't allow him to take the decisions. You have to come in. So that is where you have to intrude. So please, I think that's my response to that question. Thank you.
Thank you very
sir.
much. That was really loaded. And I mean, considering the way you talked about it, it just looks like 1 hour is really not enough to discuss depression. I mean, but just to be really short, we're going to be wrapping up in about 8 minutes, and I'm going to ask 2 questions finally. The first question, there's a question on the Zoom chat. Someone is asking the very short sentence, or if you can just summarize it, sir. Address the first line of treatment for depression. And the other question I will ask you together, I'm just going to merge 2 questions that were the 2 questions are quite similar. They were asked on our website. The first one, I'll just merge them. So what can a person do? What can you do if, assuming I'm suffering from depression? What can I do? What are the day-to-day activities to improve my quality of life? Okay, maybe you have the advice I can give a person who is undergoing or is suffering from depression. What should the person do? And does exercise play an important role? Exercise and diet, what role do they play in managing depression? So 2 questions: address the first line of treatment, and what can a person suffering from depression do day to day or day in, day out to? Yes, sir.
Okay, so first line of treatment depends on the severity of depression. That's my answer to the question. First line of treatment depends on the severity. So, and that severity of the depression is determined by the clinician. But in a situation where we have what we call severe depression, once we have severe depression, if an individual meets a criteria for what we call severe depression, yes, antidepressant medications is not really a first line of treatment in combination with the other therapies, which includes psychotherapy. So in all severities, drug is not the first line of treatment. So the first line of treatment will depend on the severity. Mild depression, we can send the individual to psychotherapy only without even giving medications. So there are situations like that. And then you resolve the social issues. So that's the response to that question. So the second question, it wasn't so clear to me. Okay.
The role of exercise and diet, and then what can the person do?
Please, in one sentence, regular exercise, good nutrition, as much as you can afford, healthy relationships, and adequate sleep. I mentioned 4 things. I need to thank the person that asked that question. so that I could mention these 4 things. I said exercise, frequent exercise, proper nutrition as much as you can afford, healthy relationships, which means you have to build relationships, and then adequate sleep. You see, these 4 things, they are very, very, very key and important in preventing and reducing the risk for depression.
Oh, wow. Thank you very much, sir. There have been a lot of take-homes for the people that have joined. I mean, personally, for me, I've scribbled a lot, jotted a number of things, and I really appreciate you for joining us today, sir. And this is a lot to actually take home. Thank you very much, sir. I would hand over to Damilola to wrap up and do what the next thing we do.
Okay, thank you very much, Deborah. Thank you so much. My co-host Ezine, she's also working in the background. Thank you very much, Dr. Itumo. I'm very sure that all our listeners have been really, really, they're really taking something important from this. Personally, I have learned a lot. I think what we are trying to achieve, like you have said, is to make people differentiate between depression and just mere sadness. Because even as Nigerians, the state the country is currently in, some people are just sad, some people are at home and they cannot tell that, oh, am I depressed, am I sad? But I'll go over the 4 Ds that you mentioned in the few minutes that we have, which said deviation from normal. That is, if something is just wrong, then there's a deviation, then there's distress to yourself, to your friends, to your family, then you can be suspecting depression. If there's dysfunction, maybe you cannot go to work, you cannot do the normal day-to-day things. Then finally, the duration.
I'm sorry, please. I'm sorry to cut you. I said 5.
Okay.
I think I didn't mention the 5th one. So the
the
5th one is danger.
Danger. Oh, okay, sir.
So the danger to self, let me give you the example in depression. The danger is that somebody who is severely depressed might have poor appetite. So that individual can go for days without even eating. And most of them can come in dehydrated and even go into hypovolemic shock. So that is already danger. So when there is also danger to self or danger to others, that is another, the 5th D. Thank you. Sorry for.
Thank you. And I think that danger, does it also involve things like cutting oneself? I think self-harm can also.
Self-harm.
Yeah.
Suicide.
Yeah. Okay, sir. Thank you very much. Thank you so much. Our guests are very, very, very well, like, they've learned a lot today. We, the host, we Health Factors, we've learned a lot. So finally, I'll just quickly talk to everyone about Health Facts. We are a media group. We are an organization that we put out health information, anything you want to learn about, day-to-day, how to improve your health. Like I've said initially, we've done Let's Talk About Infertility, we've done Let's Talk About Assisted Reproduction, and now we are doing Let's Talk About Depression. So we try as much as possible to talk about topics that affect people, their day-to-day lives, how you can improve your health, how you can improve your, standard of living, quality of life, and all of that. So we have a WhatsApp group, we have a WhatsApp community where we put out our links because we write a lot of health-related articles. We prepare quizzes for people to also attend to. So if you are willing to join our WhatsApp community, Ezine, please, can you put a link to our WhatsApp community in the chat just now before we close? Sorry, okay. Yes, I think Ezine will do that now. Then also you can actually just follow us on our website. Right? The link to our website will also be in the chat right now. So the link to our WhatsApp community is there. So Doctor, I don't know if you wouldn't mind if you can also give us your WhatsApp number or if we can put out your WhatsApp number actually, so that anybody that wants to reach out to you just to ask some questions, maybe they are going through some personal things and they need consultation or time with you. I don't know if will be fine, sir. Will that be okay, sir?
Yeah, there's no problem. I will do that. And maybe finally, before you close, just to thank you people for what you're doing. There's something they call treatment gap. The evidence we have on ground, over 80% of individuals with mental health conditions are not being treated. In a country like ours. And I think such actions like what you're taking will actually help go a long way, helping a lot of individuals. And when you look at the social situation, the economic situation in our country, it doesn't suggest that these things will get better any day. I'm sorry, I'm not being a bad prophet, but they are getting worse each day. So, but what we have to do is let us do the little we can to see if we can help rescue the situation. So, thank you
All right.
guys for the good works you're doing.
Thank you so much,
very
sir.
much.
Thank you very, very much. We really appreciate you. We are really, really grateful for you even taking time to come to talk to us here. For all our guests too, I'm sure they are saying a very big thank you to you for honoring our invitation. So we'll be closing out now. The link to the WhatsApp community, Ezine has already dropped it here. So you can join the WhatsApp community on the WhatsApp page today. We'll be putting out Dr. Dunbar in case you have anything you want to talk to him about. You're feeling a particular kind of way. You're not sure if this is depression, and this is something that is very serious and needs to be addressed. So please feel free to reach out to him. Thank you so much, everyone. Thank you to our listeners. Thank you once again, Doctor. Thank you, Deborah. Thank you so much for co-hosting this with me, and thank you, Ezine, for doing all of the hard work in the background. All right. So good night, everyone. Let's enjoy the rest of our evening wherever we are. Thank you. Bye-bye, everyone.
Thank you, our wonderful hosts.
Thank you, sir. Thank you.
I'm so sorry, I could not raise this curtain because of the reflection.